Welcome to the NeoFOCUS-UK Education Group webinar series.
Good afternoon, all, and welcome to the next seminar in the NeoFOCUS Hemodynamics series. It gives me great pleasure to introduce Prof. Samir Gupta to you all. As you will probably already know, that Prof. Gupta is a Professor of Neonatology at Durham University in the UK and also Division Chief of Neonatal and Perinatal Medicine at Sidra Medicine, Qatar. He's a member of the European Steering Group of Neonatologists Performed Echocardiography and chair of the Non-Invasive Cardiac Output Special Interest Group of the ESPR. He's the program director of the Neonatal Hemodynamic Program in Qatar and the NHRC lead for Middle East and Asia. He's the founder and conference director of the annual NeoCard conference, which I'm sure we've all been to, and that's been running since 2010 and has over 250 publications and has been invited for over 300 lectures worldwide. And he's also on the editorial boards for fetal and neonatal medicine, as well as other journals. And he's here to talk to us about the patent ductus arteriosus. I will hand the floor over to yourself, Samir, and thank you very much again for agreeing to chat to us today.
Thank you, Liam, for a very kind introduction. And also thanks to the NeoFOCUS Group UK for inviting me to share the ongoing controversies and conundrums around this very common clinical problem of patent ductus arteriosus. So over the next 45-50 minutes, what I would try and do is take you through to the relevant current evidence, have some questions that are evolving from the trials, and present options for moving forward to answer this question and also summarize what we know and what we don't know. So I have nothing to disclose. This is my current place of work, which is Sidra Medicine Children's Hospital, a quaternary care hospital in Qatar. And we have a quaternary care neonatal intensive care unit with mainly the cases such as surgical and cardiacs. If you look at the PDA journey, I go back to the two millenniums, but if you see the progress has been made since about 1800s, where we started learning a bit more about the ductus arteriosus, and in the last probably about 50 years, a lot of movement has happened because the tiny babies started surviving, and as they started surviving, the ductus was found to be coexistent, and with the availability of echocardiography, we tend to diagnose more, and the question comes up as what do we do with the duct? I think rather than finding the answers, if I may say, we have learned as what not to do rather than what we should do. And that probably summarizes to a certain extent a lot of evidence, which we can summarize saying that debunking the myths. So on the same spectrum, let's see what is there. So I don't need to take you through in details about the cardiorespiratory physiology with the PDA, but it's good to recap because it does affect. So if you look at can you see my pointer? I believe. So anyway, so if you look at the left to right flow, there is increased pulmonary flow, which causes twofold effect. One is the increased pulmonary capillary pressure due to the forward flow, and the left heart volume overload, which causes the backward flow. Because the backward flow, there is pulmonary edema that leads to increase in ventilator settings. And due to forward pulmonary pressure, there is a damage to the capillary endothelial lining. And both these effects, they cause decrease in capillary and alveoli formation, ultimately leading to what we commonly call as bronchopulmonary dysplasia. Additionally, there is leakage of plasma proteins into alveolar space, and it also inhibits surfactant production. On the ductal steal side, because of decreased post-ductal systemic blood flow, there is a decreased perfusion of the kidneys and also the gut and sometimes the brain. That causes the complications on its own. Oops. Right. So if you look at the ductus, going from birth to up to about beyond a month, initially it causes very few symptoms. but it does have hemodynamic effects. What we are talking about in the first 72 hours, and that is the reason we tend not to see the clinical symptoms, but commonly we see the findings which are picked up on the echocardiography, that is duct and its causes or its effects. Subsequent to 3 days, we start seeing the symptomatic effects of the duct with a variable hemodynamic effect. As it stays there, the body starts compensating, and we start to see the compensated hemodynamic effect. And beyond 28 days, if a ductus is patent, we call it a persistent PDA. Obviously, there are option at any point of time of not treating it, but if you decide to treat, then the windows are different. And for ease of understanding the literature, they have been divided into prophylactic treatment, which is in the first 12 to 24 hours without screening. Then from 12 hours to about 3 days, it is early asymptomatic. And then the duct becomes symptomatic as with the clinical signs and symptoms. Anytime after 3 days or so, or sometimes earlier, it is called a symptomatic treatment. We will use the same, the nomenclature throughout the presentation. So if you look at the hypothetical case, if we look at a extreme preterm infant who is born at 26-week gestational age, stabilized at delivery, given Curacao, on initially NIV and less than 30% oxygen, but on day 2 got intubated for respiratory failure, MAP of 12, oxygen of 60%. Echo shows a borderline LV function and large PDA with a LVO of 400 mils per kg. Question is, what do we do with this, right? So keep it in mind, and we'll talk it later. Now the same baby, now in day 4, and it was not treated, and on day 14, develops an acute abdomen, feet stopped, query neck, still intubated, now 70% oxygen, MAP has gone up to 14. Homogeneous opacity of lung fields, it could be evolving BPD, it could be PDA, and the echo shows a persistent large PDA, which is 3.5 millimeter with an increased left ventricular flow of now 500 mils per kg and ductal steal. Would you medically treat or this PDA or only observe? So these are our common scenarios that we face in a day-to-day clinical practice. If you start looking at the evidence before we decide what to do with these ducts, I think it is very important to mention the TIP trial, which is the largest trial on the PDA management ever done, which was in the turn of the millennium by Dr. Barbara Schmidt. And this was using a prophylactic treatment using indomethacin, started in first 12 hours without screening. And this was in extreme preterm babies, or then including criteria was less than 1,000 grams. The primary outcome was death or neurosensory impairment. And looking at the composite primary outcome, there was no difference between the indomethacin group, where it was 47%, versus placebo group, which was 46%, with a adjusted odds ratio of 1.1, crossing the limit of 1, that is 0.8 to 1.4, and hence not significant with a p-value of 0.61. There were no difference in deaths, cerebral palsy, cognitive delay, hearing loss, or bilateral blindness in the subgroup analysis, or the components of the primary outcome, I would say. Uh, Now, if you look at the various other approaches that have been used for prophylactic treatment of PDA, uh, taking account of the indomethacin, ibuprofen, and acetaminophen, you look at the severe intraventricular hemorrhage, we find that it reduces the severe IVH, which is very effective. Ibuprofen marginally reduces the severe IVH, and acetaminophen has no effect. Need for invasive PDA closure, no surprises, it does reduce. The trio kappa trial has been done on the prophylactic use of acetaminophen. It is not yet published, but from the presentation data, it does decrease the need for invasive PDA closure. That or moderate to severe neurodevelopmental disability, the indomethacin does not affect, and other interventions have not been studied for long-term outcome. This is again a very important slide that was by Bill Bennett, published in 2017. And here he did the pooled results of the randomized trials, which received the NSAID therapy. So if you look, this particular slide is showing three important components. Because of a high contamination rate, if the contamination is kept less than 50%, then this is the graph. If the gestation is limited to less than 29 weeks, it is the middle one, and the age of treatment is less than 5 days, that's the right one. So if you look at it, no matter whatever criteria you use, ductal patency certainly decreases by treatment. But if you look at the IVH grade 2, there is an improvement in all the three criterias that I've just mentioned. But if you look at the chronic lung disease, there was no effect specifically, except for under 29-week babies. Since 1990, the chronic lung disease is found to be increasing with the use of intervention. If you look at all the other outcome measures, they are not different between the intervention versus placebo. But that is quite an important, and that raised the question, which has been very well defended by Bill Banish, is about what is the rationale for treating the PDA. If you look at the traditional approaches, which we commonly use, are prophylactic treatment, the clinically symptomatic PDA treatment, and conservative treatment. If you look at the prophylactic treatment, because we treat more than 50% babies who might close PDA spontaneously, this management approach has more gone out of repute because of this undue exposure of babies to the side effects of COX inhibitors and other treatments. Also, there have been no improvement in short and long-term outcomes, albeit just the decrease in the IVH, which is with indomethacin primarily, and the concerns about the concomitant use of steroids and the risk of gut perforation. So that's a limitation of prophylactic treatment. If you look at the symptomatic PDA treatment, again, there is limited data on symptomatic treatment versus no treatment. It is mainly the trials that have been done are comparing the different agents, and also included babies which were much bigger, as they included babies up to 34 weeks. I think that I would not like to criticize that, but at the time when these trials were done, the concern was up to in babies which are up to 34 weeks. So question was right for the time, but obviously there are no, for today it does not help, but there were no differences that were reported as such on the limited data. And in addition, there are quite high open treatment rates in all the trials, which can go up to as high as 87%. The more commonly practiced approach, which is least evidence-based, is a conservative management. It has evolved not by the proof of the evidence favoring conservative management, but due to absence of benefit secondary to any intervention that we have used. So that is the reason why I think the conservative management has been out of the concerns of the clinicians finding no benefits of the intervention. So this is one of the trials that was done almost about 15 years ago by Dr. Benklari's group in US. The question that was raised was, should the baby be treated with early symptoms of PDA? Now here they were not using the echo to identify, but they looked at the clinical findings. So it was a double-blind randomized trial, early treatment versus expectant management, and the gestational age was under 32 weeks. Echo were subtle PDA symptoms, not necessarily very full-blown symptoms, but if the baby had a heart murmur, metabolic acidosis, bounding pulses, the baby was randomized to treatment versus no treatment. The median age of early treatment was 3 days, and the expectant group received in about 20% the ibuprofen at the age of about 11 days. In addition, the about 50% expectant infants never required any treatment because of the closure, and there were no differences in the outcomes, that is oxygen 28 days, death, or complications of prematurity. This was one of the early trials which was done to see whether a soft signs of PDA as early as they appear, and if we treat it, does it make any difference? But again, negative results never supported the evidence of treatment. Coming to the even going back in 2007, that was Matt Lone and Carl Bose from US. They had first published this particular paper, which started the whole controversy about treatment. Until then, the treatment of PDA was more of a default approach rather than an option. And that was the time when indomethacin was very widely used for prophylactic treatment after the results of the TIP trial, though not showing but decreasing IVH. And also, the closure of the duct was more of a norm. What he reported at that time, with the prophylactic treatment, mainly used combined trials on indomethacin versus control, the mortality, there was no difference statistically, but clearly it is coming towards the treatment side. The chronic lung disease, no difference. The neck, no difference, but clearly symptomatic PDA, IVH, they decreased. The asymptomatic treatment was also looked at, and here there were no differences in any outcome measures except for the symptomatic PDA. And what they put up in their commentary, which still holds true after all these years, is treatments to promote closure of the PDA cannot be justified on the basis of proven benefit unless one finds a reduction in severe IVH with the prophylactic administration of indomethacin a sufficiently compelling benefit to justify its use. Now, a word about the IVH here, that our IVH rates have gone significantly down. And will this intervention make a further difference is a big question. Units where the IVH rates are very high in extreme preterm babies, this is one of the options still could be considered if you want to reduce the IVH rather than closing the PDA. Now, this is a paper you would have all seen about, is by Dr. Selmer from Scandinavia. That is again around the time when Sosenko paper was published from Dr. Benklari's group. What they reported is various complications of prematurity, as they are seen, they are significantly increased if the duct is open in babies below 28 weeks and is more than 1.5 millimeter on day 3. That means a duct open on day 3 is a significant risk factor by increasing the odds of IVH, certain degree pulmonary hemorrhage, neck, and also chronic lung disease, including mortality. So that was significant concern at the time, and it has been very widely quoted about the observational data leading to the concerns about the complications of prematurity linked with the PDA. And in the last 20 years, we are also having increasing interest in the echocardiography on the bedside, and that is where the new millennium approach, I call it, is that the bedside echo identifying the PDA causing rather more confusion than answers. Because initially a duct that is found, which was clinically not perceived, that was a big question, and people started treating it. Now the pendulum is swinging, and we are getting more data to probably answer it. What should we do with this duct? If you look at the various assessments of the duct, which you all are aware of, one is the duct dimension, which is a left to right flow. As you can see, the red flow out here. The pulmonary flow, which increases the left atrial to aortic root ratio, so left atrial diameter to the aortic root diameter. If it is 1.5 or more, it is said to have volume effects on the left atrium, causing dilatation. And the ductal steal, which is causing reversal or absence of flow in the postductal vessels, primarily seen in the descending aorta or the superior mesenteric artery. Using this data in long back in 95, Dr. Klakow and Dr. Evans first published this as the sensitivity of utilizing these parameters, though criticized now by some people, some of the clinicians, is pretty high reported. So a duct that was more than 1.5 millimeter 24 hours had an 81% sensitivity that it would require the subsequent treatment and will be symptomatic. Left atrial to aortic root ratio, the specificity was very high. LVO of more than 300 mils per kg, the specificity was very high, and ductal steal had a high specificity. All of these had a very high positive likelihood ratios, and that is something that has been used in practice even now. Utilizing this approach, the first trial of the echo guided management of PDA was done by Dr. Klakow, and that was to overcome the limitations of the prophylactic treatment, where all the babies receive treatment irrespective of duct being there or not. So in this trial, they had babies below 29 weeks who are less than 12 hours old, get a cardiac ultrasound. Based on the criteria of the DETECT trial, they defined large duct mainly on the duct size. And they were dividing into treatment group and the placebo group, followed up. And you can see that the open treatment rates were not very high. It was 20% in the treatment group, 40% in the intervention group, in the placebo group. And the standard unit care was then scanned again on day 7 and 14. And their primary outcome was death or abnormal kidney ultrasound. This trial unfortunately was stopped very early after recruiting only about just over 90 babies, and the reason was non-availability of the drug. There was no difference in the reported data on the primary outcome, no difference in death, the intraventricular hemorrhage, PVL, and by gestational age stratification also, there were no differences that were observed between the two groups. The only finding that reached significance was the pulmonary hemorrhage significantly reduced in the group where indomethacin was actively used. So the DETECT trial, obviously a very well planned trial, could not answer the question because it was stopped early and then the drug was not available. The data from the early treatment versus expectant management, if you look at if the treatment is initiated before 72 hours, and these are the trials which were done before 2020, or rather reported before that. It had 383 babies, 7 trials, sample size were small, and there was no difference in the risk ratios for all-cause mortality, surgical PDA ligation, chronic lung disease, severe IVH, and necrotizing enterocolitis. There was no difference demonstrated between early treatment versus expectant management of hemodynamically significant PDA. So that was what we knew from the before 2020. On the turn of this decade, if we look at what trials have come up, because some large trials have been published and the data presented. So the TRIOCAPI trial, which was designed by Professor Véronique Gornet in France, and this is dedicated to him, who sadly passed away, and it was then presented and published by Dr. Rose. It was a multi-center, double-blind, randomized trial in 11 French units from April 12 to December 16. Babies were less than 28 weeks. Standard dose of ibuprofen was given, and it was screened before 12 hours of age, and seen if the duct was large. The control was a matched placebo, and the primary outcome was survival without cerebral palsy at 2 years. So I've taken away the data which were the babies with a small duct that is below 1.5 as per the criteria, and 228 infants that were born below 28 weeks with a large period echocardiography at 6 to 12 hours screened, were randomized to ibuprofen or placebo. The primary outcome, as I said, was survival without CP at 24 months corrected age. This is the data on the primary outcome. If you look at the placebo and intervention and the adjusted risk ratios, by modified intention to treat analysis, with and without imputations, there is no difference. And per protocol analysis, again, with and without imputations, there is no difference between the study groups. The short-term outcome data from the secondary analysis, if you look at, there is slightly more a trend towards more deaths in the ibuprofen arm. Pulmonary hemorrhage clearly almost reaching significance, less in the ibuprofen arm. And the BPD was only marginally less again in the ibuprofen arm. NEC was no difference between the two groups. The question that was defeating the results of the trial was the open label treatment. Placebo had 62% open label treatment. Ibuprofen had a reasonable, that is 17.5, which was statistically significant. The more important thing was the open label rescue treatment before day 3 was given in about 33.8%, and the median age of giving it was 4 days in the placebo and 4 days in ibuprofen. So it was more or less in the window of the early treatment of within 72 hours, when the treatment was given very early in the placebo group in about 60% of the babies. So that the results need to be taken with caution here. But what I presented is, again, a very well designed trial with the within first 12 hours. And in the intervention arm, the closure rate was about 72%, which is pretty good. Then comes the Benedictus trial that was again published recently in NEJM. The Benedictus trial, the hypothesis was in extreme preterm infants with the PDA, expectant management is not inferior to early treatment. This was a non-inferiority trial with a non-inferiority margin of 10%, and they required a sample size of 564 infants. The trial protocol, I'm sure you all are aware, is echocardiography in 24 to 72 hours. And if they find a duct, then they obviously more than 1.5 millimeter, they were randomized to receive treatment or expectant management. They give one course of treatment, then they evaluate the duct. If it is closed, they follow up. Not closed, they give a second course. If the closed, follow up. If not closed, then they are sent for the ductal ligation and then followed up. So it is definitive closure of the duct with multiple courses in the treatment arm. Expectant arm, there's a blinded echocardiography that was done, and the number of babies reported in the trial were only 2 from what received an open treatment. However, about 40% babies did receive paracetamol after the randomization for other reasons, which can still close the duct. So the results of the Benedictus, if you look at, the composite primary outcome was neck or moderate to severe BPD or death, and the risk ratio was significant in favor of the expected management. Per protocol analysis also, apart from the intention to treat, it remains the same. This was primarily dictated or affected by the moderate to severe BPD, as it is 0.66 with a risk ratio of 0.48 to 0.90. So clearly giving the drug, it was causing a significantly higher BPD, leading to the trend what you are seeing here. But I'll just like to draw your attention again here. If you look at the death between the early ibuprofen and the expectant group, there is almost about 4.2% difference. Again, this is higher in the early ibuprofen group. Then we come to the baby Oscar trial, again published last year. This is in NEJM again, which is a multicenter trial in the UK, where babies who were born 23 to 28 plus 6-week gestation, less than 72 hours old, large PD on echocardiography defined by the duct dimension and the flow pattern, which is very sensitive, or the criteria to screen and include. The intervention was standard ibuprofen dose of 10.55 milligram per kg 24 hours apart. The placebo was 0.9% sodium chloride. Again, matched placebo. It was double blind in the same ampoules. And the outcome was death by 36 weeks or moderate to severe BPD at 36 weeks post-menstrual age. We also had a long-term follow-up for neurodevelopmental and respiratory outcomes, which has already been published in the Lancet series, and also the health economics data is also published now. These are the inclusion exclusion criteria. I won't spend time going through that, and it is available in the print. And as I mentioned, they are the short-term outcomes and the primary outcome, and the secondary long-term outcome, as I mentioned, at 2 years of age. One of the things I would like to mention here is a randomization 1:1 with minimization. And the minimization was mainly to balance both the study groups by each week of gestation. So it was minimized by gestational age, by center, so that it is equally dispersed. Then was the baby on an invasive ventilation or non-invasive support or no support? Then was the baby receiving inotropes at the time of randomization or not? So all these criteria, apart from the duct size, which was 3 categories, 1.5 to 2 millimeters, 2 to 3, and more than 3. So both the groups were fully balanced for each of these criteria, and hence one can do a subgroup analysis, which was pre-planned, and it gives a complete balanced assessment without minimization that could have been difficult. If you look at the primary outcome, the death by 36 weeks or moderate to severe BPD, 69.2% ibuprofen, 63.5% placebo, and the adjusted risk ratios, which is adjusted for the minimization factors, was not different between the two groups. Next, we look at the short-term outcomes. Again, death by 36 weeks, there is almost about 3.3% difference, a bit higher in the ibuprofen, but not statistically significant. Moderate to severe BPD, slightly higher, but not statistically significant. The intraventricular hemorrhage benefits are lost, which were seen in the other trials, because probably the late intervention is after 24 hours more commonly. And the significant pulmonary hemorrhage, neck, they are not different, but the closed or non-significant PDA was higher, obviously with the ibuprofen treatment, as you would expect. And the open label treatments were very controlled, only 14% in ibuprofen and less than 30% in the placebo. If you look at the subgroup analysis for the primary outcome, by each week of gestation, you can see that there is no difference each week of gestation for a good number of babies included in the trials for each week. If you look at the size of the PDA, which are the 3 groups I mentioned, again, there is no difference between the groups. If you look at the mode of respiratory supported randomization, if the babies were invasively ventilated, then clearly there is no difference, and same is for non-invasive ventilation. So look at the subgroups, the primary outcome was not different. Now we look at the components of the primary outcome for the same subgroup analysis. Is BPD moderate or severe? No difference for each gestation, no difference for size, and there is no difference for the mode of respiratory support. But obviously you can see the trends are all favoring the placebo. If you look at the death, although for each group it is showing that it is favoring the placebo, but not statistically significant, except for the babies who are invisibly ventilated. The risk ratio is 1.43 with a 95% CI of 1.01 to 2.01. And the number of babies are in excess of 400. So I think this is something, they are sick babies, and if we treat them, what the trial results are showing that it is favoring the placebo here. This is a post-hoc exploratory analysis not published, and you can see here that if we exclude all babies that received any open label treatment, we are still left with a fair number of babies, that is 278 in the ibuprofen arm and 226 in the placebo arm. You look at death or moderate to severe BPD, 65.4% and 55.6%, and now it reaches the significance with a p-value of 0.045 and the adjusted risk ratio of 1.14 with a 95% CI of 1.0 to 1.29. So post-hoc analysis, so clearly this is not the per protocol, but this is excluding the infants who received any open label treatment. Again, the death difference remains the same. The PPD direction difference, it magnifies a bit more, does not reach significance, but it is favoring the placebo. Now, we published the meta-analysis on a systematic review, not in a full detail, but we looked at the death primarily here. And what we did is combined the PD-RCT, which is by Afif and Khawash, then Trio Capi trial, Benedictus, and Baby Oscar. These are all recent trials, which uses more like a similar protocol of early treatment in the same group of babies, which is extreme preterm babies. And what we find is the hazard ratio is now found to be significant and is 1.37 with a 95% CI of 1.05 to 1.78, and that is statistically significant. So clearly, every trial is giving a hint of more deaths with the intervention, and it is in the pooling of the trial data, it shows that this is a significant concern. We also looked at the long-term neurodevelopmental outcome at 2 years, and you can see survival without moderate or severe neurodevelopmental impairment is not different between the two study groups. And the long-term respiratory outcomes, this is the first time ever reported, is survival without respiratory morbidity. Again, it is not different between the two groups, but the duration of oxygen supplementation is longer in the ibuprofen group by about 10 days, about a median of 148 days, as compared to placebo group of 138 days. If you look at the subgroup analysis of moderate to severe survival without moderate to severe neurodisability, again, no differences for each of the subgroups that we have specified or pre-specified, and there are no differences between the two groups. So where we are in the next few 10-15 minutes, we are going to close up on this. So early PDA screening and treatment with ibuprofen in extreme preterm babies. What we know, it increases the closed or insignificant PDA, we know that. It reduces the need for surgical closure of PDA. There's a trend towards higher moderate to severe BPD. There's a significantly increased risk of death, but no difference in the long-term outcomes. But obviously, we need to also look what are the limitations of the current trials. I think I'm giving two examples here because large trials. The Benedictus trial was supposed to have 564 infants, but it recruited only 273 infants, that is less than 50% of the planned sample size. Baby Oscar trial had a power of 90% for a sample size of 730. We recruited 653 infants. That gives us the sample size is 89.5%, and the power has reduced from 90% to 86%, which in my view is still a respectable power of 86%. Use of drugs after randomization, there is contamination in all, like Benedictus, as I said, after treatment, 38% in the early treatment and 25% expectant group did receive paracetamol, though for a different indication. Baby Oscar trial, 14.8% and 29.4%. Triocapi, 17.5% and 62.3%. So we cannot get away with the open treatment in the placebo arm or completely later open treatments in the intervention arm. Now here we look at the closure rates. So when we give a drug, our plan is to close the duct definitely, but we are able to close only 50 to 70%. If the treatment is started in the first 12 hours, our closure rates come to about 70% plus. But if it is after 72, after 24 hours and the first 72 hours, it goes to about 55 to 58%. So the true difference between the study groups, when we look at, is only about 18 to 35% and not 100%. To achieve this, one has to plan a trial where there is a 100% closure, for example, using a device, and no treatment in the placebo arm. That would give us the pure data. However, from our the trial data we are looking at is the based on the duct that was closed or open and what effects it closed, and that will be again a post-hoc analysis. The magnitude of shunt volume and duration, it was not studied longitudinally, and that is an increasing interest that is being mentioned by some of the groups, that the shunt volume is important, and we need to probably monitor this to assess its duration. So ongoing questions and controversies have been raised about the selection criteria. What is the benefit in less than 26 weeks? And does the choice of intervention to close PDA it affects outcomes? Now, various scores have been used from Sher Zedek to Madrid, Al-Khafash, and Iowa. The differences are that the PDA diameter, PDA flow pattern, ductal strain, and left heart volume loading is used for all the scores, right? The two scores, which are the Iowa and Al-Kufash, they also, in addition, use the cardiac function, mainly the diastolic function. And it has been suggested that assessing a cardiac diastolic function, it improves the pickup rate and identifies the babies which are truly having a significant duct. To update you on this, this is the study from Japan, published 2019, where extrapreterm babies were taken, and the rock analysis was done with the area under the curve. And it's still, they reported PDA diameter has a highest area under the curve and gives 0.86, followed by left pulmonary artery and diastolic velocity and left atrial volume. If you look at the Al-Khafash score, this is a cutoff of 5, and it has a sensitivity of 92%, 87% specificity. And as I said, they have used the gestation, the PDA diameter, left ventricular output, maximum PDA velocity, and the ACE prime wave in the left ventricle. So basically, they are looking at the heart function in addition to the flows and the left heart volume loading. Now, does it make a difference? Let's look at the study done by, again, Afif, where the PDA-RCT was done. It was utilizing the Al-Kufash score, and they had it's a small trial, 30 babies in each arm, and ibuprofen and placebo, using the same, the study protocol. Gestation median 26 weeks. PDA risk score was over 5, 7.4, 7.1. PDA diameter was about 3.1, 3.4. High left ventricular output, but it is, sorry, not high, but it's normal ventricular output. PDA velocity was this, A prime was 5.1. Now, if from the same data you look at the chronic lung disease or death was in the ibuprofen arm slightly lower, right? If you look the chronic lung disease in survivors, clearly there was a benefit in the ibuprofen arm, but at the cost of almost double the deaths. So 28% deaths versus 13% deaths. So yes, by identifying the babies more appropriately, there could be a benefit in reducing the chronic lung disease, but it comes as a cost with the increased death. So it is again a question that is still open whether it's a safe way to move forward by selecting babies more objectively, utilizing better criteria. But what the outcomes are going to be, we need to be looking into large trials. Now, the question was about under 26 weeks. Are there enough babies? And Baby Oscar trial in itself had 445 babies, which are 26 weeks or less. But as I mentioned, if you look at below 26 weeks, even up to here, there are no differences in the primary outcome of death or BPD. So learning from the history, I would take you back to the oxygen saturation trials. It was more of a dictum, I remember, because Dr. Winton and I worked in the same unit, and it was a practice based on the very convincing observational study that lower saturations is a way forward because it reduces the ROP and reduces BPD, and there are a lot of advantages, and that was a practice at the time. Until there was the NeoProm collaboration and the boost, the COT, the support, all these trials were done, and they reported concerns about the initially from support trial increased death in a low saturation arm. This was later in a meta-analysis confirmed that yes, treating the babies and keeping saturation low, it significantly increases the death before discharge, or discharged from the hospital. Clearly, there is improvement in the ROP, there is improvement in the BPD, but the neck also it increases. So clearly, there are benefits in some, but death is such a hard outcome that nobody want to compromise on this, and one has to be very cautious of picking up a treatment. And we are seeing more or less the same finding in the PD8 recent trials of early targeted treatment. The death is significantly increased, but if you super select like the PD-RCT, there could be some benefit in reducing the BPD. So the question and the jury is out as what and how you perceive the evidence. The Bayesian meta-analysis also done by Dr. Willamore is also showing that the trials that have been done, the Benedictus and Baby Oscar, they are of a moderate evidence for the mortality uh, causing the harm. If you look for the BPD, it is moderate to severe evidence, very strong data to support this, and BPD on its own is very strong data. So there is a moderate data which is suggesting about the concerns about harm, which is death. Moving forward, I think we cannot stop here. We need to do more studies. And what are we going to answer? So the question is, should we wait for PDA to be symptomatic before we intervene? Choice and efficacy of pharmacologic agent and the choice of primary outcome. Interestingly, what is you see there are different types of the PDAs, and in the preterm babies, this is the commonest PDA, which is F type. It's seen about in 79% of the preterm babies. This is a difficult PDA to close. As you can see, it is long tortuous PDA, and hence that is the challenge that is there. There are various different types, but in the preterm babies, this being the type of PDA, there's a constriction and reopening, which is very commonly seen. It's a very good slide from Afif, which is how do you define the hemodynamic significance? We look at the shunt volume, pulmonary overcirculation, systemic hypoperfusion, and that is very commonly used on the echo. The heart adaptation is important, and that is the reason why the diastolic function was brought into the equations using the scores to assess the systolic diastolic function. But the gestation using the premature lungs and the status of the brain, gut, kidneys are very important to look at. So when you're defining hemodynamic significance, I think one of them taking a note on its own might not be sufficient, and it's a need that we take the clinical and the echocardiographic criterias. Apart from that, the heart function to define the hemodynamic significance, which might be the way forward from the large trials. So if you look at this data is from Anne-Marie was part of Dr. Anne-Marie was part of the PD tolerate trial and can throw light on that, where they have done the postdoc analysis done by Dr. Ron Kleiman, where they report the BPD grade 1 to 3 is here. The clear boxes are the grade 1 and the dark are grade 2 and 3. And on the x-axis, it is giving the length of the exposure to moderate to large PDA. So what we see here is if the PD exposure is anywhere about over 10 days to over 14 days, the BPD of and is intubated for more than 10 days, then the risk of moderate to severe BPD is significantly high. So a baby that is more than 10 days intubated has a exposure of the moderate to large PDA for 10 to 14 days, they are at significant risk of this grade of moderate to severe BPD. The same has been found from the TRIO-CAPI trial again, that intubated babies over more than 10 days. And here they found a bit more that even below 14 days, the BPD grades were high. But clearly, if it is more than 14 days, it is significantly higher. So this is now a post-hoc analysis data which is generating the hypothesis that should we be selecting babies who are over 10 days old intubated with a exposure on the shunt volume. This is again very clearly shown that babies who are born between 2005 and 2018, that's again observational data, who survived less than 7 days were excluded. Those who survived more than 7 days were 423 infants. Duration of PDA shunt and exposure to moderate to severe BPD was studied. And if you look at the moderate to large ductus duration, if it is the closed ductus or small ductus, there is no concern. If it is 7 to 13 days of exposure, as you see here, um, then the risk of BPD, it is 45%, and this is based on the exposure, so moderate to severe BPD. So babies intubated for 7 days with a moderate to large duct, they could be the group where we are looking at might have some benefits and avoid the harm that we are seeing in the first 3 days of treatment. Ibuprofen on its own, is it a safe drug? I think that's a question where the study clearly shows that if you give ibuprofen and the duct does not close, the risk of developing the BPD is significant, is much higher than those who respond or those who close the duct. So ibuprofen exposure on its own is not safe. It does affect the alveogenesis and the other medications that are there. I think we need to also look for that. And one of the medications is paracetamol. When you look at paracetamol versus ibuprofen, failure of PDA closure after first course, no difference. All-cause mortality, no difference. Neck, no difference. You look compared with the placebo, obviously there are advantages of the paracetamol because it closes the duct. Early paracetamol, the same findings. Late paracetamol, the effects are not the same. And paracetamol with ibuprofen versus paracetamol versus ibuprofen, there is no difference. So paracetamol is again, there's a lot of interest mainly because of the concerns about ibuprofen, what people have. But it is not still safe from the early data presented from the trio kappa. It shows the concerns about the cholestasis, and some of them it is not reversible. So, and the concerns about the autism, which has been reported from the animal studies as well. So one has to be cautious before we get onto the drug. But clearly in babies with acute abdomen, this is a good drug to try if you are going to close the duct. Now, this is a slide which has very commonly been shared by Dr. McNamara, and that is the significant change in the survival of the babies, or not survival, but the death or severe IVH, that is seen after 2018, and it is decreased quite significantly in the babies which are very, very preterm. Now, what they have reported is the practice that has been changed in 2018 with the hemodynamic practice incorporated in the routine, which is the hemodynamic screening. Now, I would like to draw your attention that yes, this is great, and Iowa is known for increased survival of the extreme preterm and also 20 to 23-week babies. And the benefits that have reported over here are for the babies that 22 and 23-week babies, right? So, what is their approach? And I think that is the approach which is quite a good bundle of care for extreme preterm babies. PDA is one of those things which they manage if they find a high volume shunt. They treat with the paracetamol, and they can go up to even 28 doses to close it, or then follow up with indomethacin, or otherwise go for a device closure. But equally, if they find at the screening there is acute pulmonary hypertension or cardiac dysfunction, they treat it accordingly. This is something that is missing from the jigsaw for many other centers. So all the benefits that are being projected are not due to the PDA treatment using the approach, but it is the composite or the bundle of care that is used to manage the other parameters like cardiac dysfunction and acute pulmonary hypertension. Also, the benefits have only been reported in 22 and 23-week babies, and the data is not there for the similar babies beyond 23 weeks. And that is a question that obviously stands, and it begs randomized trial to prove this because it's a single center experience still. Now, where we are is that is a lot of treatment. This is observed to expected treatment. If we are treatment on the higher side or treating in a unit with a lower size, they both increase the death or severe neurologic injury. But if you are a bit moderate in selecting the babies, then the death or severe neurologic injury is the lowest. The question is about case selection, and that is where the big question is, how do we select these babies who will most benefit from the treatment? So early screening for PDA and targeted treatment, what we know is current evidence does not support echo-guided early treatment of PDA and Elgans and ibuprofen. Early selective treatment of PDA could be used as part of the well-designed research protocol. A comprehensive evaluation is and better selection criteria should be incorporated in future RCTs of PDA treatment, and interventions with high success rates, for example, device closure of PDA with minimal contamination in control group, need to be evaluated further. There is a plan of moving this trial in Europe, and I think it will be good in times to come in next 5 to 10 years. We have the answers. Large trials recruiting sample size and incorporating long-term outcome should be planned to guide the clinical practice. Until then, I think we do have a responsibility till we have a convincing data of what is the right way forward. We first do no harm. And that is the famous quote from the Hippocrates. And I think we still need to follow this just as we have followed about the saturation trials. Same thing applies for the PDA trials. Thank you very much.
Thanks very much, Samir. That was a fantastic talk. I'll now hand over to our moderators, which is Bikash and Mahmood, and from the executive committee from the NeoFOCUS group to go through some questions which might be in the Q&A box, which please fill in if you have any questions for Prof. Gupta, and I'll hand over to these three now.
Thank you. Thank you, Liam. Thanks, Samir, for this fantastic talk. Very elegant talk, as always. Really very comprehensive, run through all the evidence so far. So I appreciate your time and effort. So I will just start with a few comments, if that's okay.
Sure.
Until we get some questions on from the attendees. So obviously, we still have some, debate and controversy, and I think it's gonna go on for a while. But few observations from the evidence, Samir, and please correct me if I'm wrong. So obviously, most of those trials, as you already beautifully illustrated, they have limitations. We probably haven't looked at the right population. We haven't answered the right questions, or at least many of them, because I know, as all of you guys, you know, the duct will close at some point. But the duration of the chronic shunt is probably the most important thing. Many of those babies, particularly the ones less than 24 weeks, let's say, they might take up to 70 or 80 days for their duct to close. Is that duration of chronic shunt harmless? I would argue against that. Also, as you already explained, the duct diameter is sensitive in many areas, but there are anatomical difference in the duct, and some of them is not like a tube, like a continuous tube. So the duct, wherever you measure it, might differ. So also this is important to consider. The other thing about the timing of that treatment, many ducts are actually protective in the first day or two. So treating that might cause death or harm. So we haven't looked into that when we studied the, those babies. So I would like just your comments on those observations.
Sure. No, thank you very much, Mahmood. I'll answer your first question. The last question is about the ducts which are helpful for the offered in the RV. Now, the exclusion criteria, I will talk about the baby Oscar trial, being the largest in the early targeted treatment ones. The babies with pulmonary hypertension or more than 30% right to left flow were excluded from inclusion. So that takes away the anxiety about the duct dependent RV function, which is it required. So we are reasonably, confident that we have not included babies with pulmonary hypertension. And in the subgroup analysis, again, there are no differences in the data. Coming to the selection criteria, and you rightly said, as I showed in one of the slides, about different types of ducts and why the premature ducts, which are tortuous ducts, are more difficult to treat because of the tortuosity. Now, the reason why we took the flow pattern along with the dimension was for the same reason, so that we do not include a restrictive duct in there. And we truly take account of the ducts which are, moderately large, which is over 1.5, with a flow pattern which is pulsatile. A pulsatile flow pattern clearly shows that it's a non-restrictive duct. So that is overcoming this area. Now, the first question was about the selection criteria on these babies. Clearly, when the trial is designed, it is designed based on the question that is at that time. When we designed the trial, it was going to 2010, 2012. The question that was faced is about extreme preterm babies. Even if you look at the BAPM criteria, the 22-week babies were not given any intervention. It was 24 weeks onwards, 23 was discussed as per the parental wishes. So clearly things have moved since then. I still would like to disagree with people focusing on 22 and 23-week babies. The reason is we have a great lot of work to do for babies which are 24 to 26 weeks before we jump onto 22 and 23. It looks very exciting, makes the news headlines. 283-gram baby survived and is 1 year old. Fair enough. How many of them, right? So I think what is first is that if we can improve the outcome of babies, which we are now able to do over 28 weeks, we don't worry so much. We don't even treat the duct. That was a practice, 20 years ago. Now we have moved away from that. The same question is for babies 24 to 26 weeks. Yes, we cannot forget the babies who are 22 and 23-week babies because they have started surviving. Their physiology could be different. And hence, the selection criteria that have been used for a trial, as I said, about 30 years ago when the babies are recruited up to 34 weeks, that was the group of babies. So to say that the selection criteria were incorrect, I would differ with that. The selection criteria were appropriate at the time when the trial was designed to answer a question, which was the question of that time. We have moved forward now, and the question of today was not the question of yesterday. And hence, that is the reason why ongoing further, I think the trials that need to design are based on the technology, because in the group of babies we are interested, we don't have a device to put it in there. So the device cannot go below 700 grams, and we are talking about babies which are below that gestation who require the device. So we are dependent on that. So the expertise is also linked with what we want to answer. Otherwise, the side effects are more. So we will have to wait to find the right answer. But until then, based on what we know, the only thing that I would like to share is what we know based on that evidence. I think it's a good data which selects the babies appropriately without over selecting the babies which are at low risk. And I think it proves the point, and that is the reason why people have a great anxiety of treating the babies left, right, and center nowadays.
Yeah, thank you, Samir. I totally agree with you. There are old trials already been incorporated in recent systematic, reviews and meta-analysis, and we need to be careful about that.
Yeah.
We've got some questions already. Bikash, do you want to come in?
Samir, just while Mahmood, if you mind collating this question, I just have one question, Samir, and I hope Liam, you okay? We run 5 minutes, 6 minutes extra because it's not every day we get Samir on with us, so it will be interesting. One is Samir, and one means on a similar approach, and in line with your presentation, which you mentioned, is one of the data you share was Iowa data, which we all talk about, and where you did mention about their approach. And what my take on that and what my practice from that has been is more a phenotype-based approach rather than just also extremely. So what I'm trying to do is to phenotype the duct, not only on basis of gestation age, but on a lot of other factors in it, which includes functions, which looks other stuff. And depending on the phenotypes, I would worry when we not phenotype those babies properly and start treating them, you're causing them harm. And that's my biggest worry. However, if you phenotype them properly and have a phenotype-based approach and think about not only conservative management, for some babies, a conservative management would be useful. For some babies, a trial of ductal elimination I know we don't have a magic bullet over here or a holy grail how to treat, but there are various options we have. And depends on the unit you are. If you have a surgical unit on site, that's a different thing. You can give a device closure. For a unit which is 30 kilometers away, I would be hesitant to put the baby on the back of an ambulance and sending them for device closure. So limitations are there for it. So whatever you have, but thinking about ductal elimination at their state. And similarly, a trial similar to that need to be done. We completely agree. But while we don't have a trial like that, and if I have a baby who I've seen a hemodynamic phenotype, which is causing, to me, physiological problem to this baby, how do I ignore it and not treat it is a question as a clinician, which I'm burdened with.
Excellent question, because always. So I fully agree, and I'm fully supportive of the bundle of care, which is very beautifully put up by Regan in the slide which I presented and practiced in Iowa, is about you screen at 24 hours, you find where the problem is. And that makes a big change because duct will be there, in everyone,
Yeah.
right? It is very unlikely the duct is closed. So duct is open without any pulmonary hypertension, without any cardiac dysfunction. I think, given the current evidence, we are pretty good in there because there is no rush to treat this duct. You find a duct with a pulmonary hypertension, right? I think the point is about, despite the INO trials which have failed to report on any benefits of the nitric oxide in this group of babies, but we do find in IUGR babies with the pulmonary hypertension, and if you're stuck, and babies they come out and they do well. So by screening, if you find that, and if you treat pulmonary hypertension, that will certainly improve the outcome. Same is with the cardiac dysfunction. So I think what you have mentioned is about defining the phenotype of the duct based on the assessment is quite important. Now, what do we do with that is the second question. We know the drugs that we use now, is closure a problem or a drug a problem? We don't know yet because it is hard to dissect that evidence. So based on what we know at the moment is, if it is causing a symptom or a significant problem, there is no reason by selecting these babies. We need to study from either a registry till the data is there on the trials or randomized trials, that how are the outcome of these babies affected by the intervention. So one of the things I would like to suggest with a concerted approach of having a very good trial a registry, like a program grant, of putting in the data and then getting the information, which should be a clean data to get it out, would probably start answering some questions and generate hypotheses. Because it will take another 10 years otherwise, if we have to wait for the next trial to come in. And until then, what do we do about these babies? We are technology dependent. We are, knowing what we know is a concern, and rightly so. People will not take the death as an outcome of interest by reducing the BPD. And that is where it is important. So you are absolutely right. Phenotyping the duct along with the other hemodynamic parameters is and should be immediately adopted, because that will certainly help not necessarily a duct, but the babies with the other problems by screening. So screening is must, but what do we duct? I think that is to be guided accordingly.
Oh, thank you. Thank you. Beautifully answered, Samir. And this is what I would advocate too, in terms of phenotyping the duct, and probably do what you are, in terms of your local support, what available treatment you have, you offer back to the patients, actually. I think so we would have,
Yeah, I've got some questions
yeah,
here.
please.
So I will try to combine a few of them, because I think you've already answered some of the questions in the last kind of conversation. So people are asking, obviously, because of the limitation of RCT, should we just manage PD individually based on patient approach and physiology approach, rather than just using a blanket treatment? I think you've answered that. And also about applying early TNA approach to screen regardless of the symptoms. I think we all agree about that. Also, doing a device closure versus placebo, is it pragmatic and ethical? I think that's a big question for debate, but I will let you chip in, Samir, please.
Sure. No, I think it is an ethical question, because we have already done a trial of intervention versus no intervention and limited the intervention, which has been shown that parents do accept the trial methodology. It may not be in UK to the same extent, but we can certainly try. In Europe, it was more easier. Australia, it was possible. That ethically, the IRB or the ethics committee allowed not to treat the duct in the placebo arm. Moving forward, there is a European interest that is developing, which is planning a trial, obviously in due course, which is going to be exactly the same device closure versus the expected management, but not in the first 3 days. They will be looking into the babies who are almost a week old with a shunt volume and are dependent on ventilator. So in the group, is a certainly change the focus from very early treatment to about a week old, and that's what they're designing on and putting it up as early treatment, expected management versus a device closure, and see the outcomes of interest. Again, one thing I'd like to put in here, so people have asked, why should we always take BPD as outcome of interest? And I fully agree. Why should the BPD be there? Because now we are questioning the BPD definitions as well. Is it defined to be at 36 weeks, at 40 weeks? Should it be defined later? Or is the long-term outcome more important? And I think there comes the importance of the parent groups, which should guide what the outcome of interest is, apart from the clinicians deciding, because that might not be of importance to the parents. Right. So right outcome, and that is another time, a discussion on what is the right outcome, and what is of interest to clinicians, what is of interest to parents.
Absolutely, Samir, because, for an extreme preterm baby, 23, 24 weeks, this is a very long journey. So many variables, confounding. It's not only PDA. People get fixated on PDA, but I think there are bigger problems than this.
Mahmood, if I just one comment from me, because for a wider audience who are listening to Samir and other people, and if I don't, Samir, I just want to see whether you would agree to my statement of this and validate this, is there is somewhere, and I see among my colleagues and other people whom I see, is they're interpreting the outcome of the evidences which has come out as duct doesn't cause problem and we should not worry about duct. But I really want people to understand that duct is a problem and CAS can cause a problem. We don't have a magical treatment about it, but it's important that these babies are assessed properly hemodynamically, and a cardiovascular care bundle is put in place to support this baby, and an individualized treatment is important rather than saying as a blanket policy, we don't screen the baby for duct, we have stopped screening, and it's not a problem at all.
Thanks, Vikas, for bringing it up. And I fully agree. We are, in fact, writing a position paper on that, is to guide that, yes, the trials that have been done, they are very well designed and very well done trials, and it is not easy. But there are limitations to the trials. And hence, it leaves the caveat as a group of babies which would need a treatment. And it's not an all or none raw. And unfortunately, in a lot of interventions that we do in neonatology, like any other specialty, the pendulum, it swings from one into the other. And I'll just give two examples. I've told you about the saturation trials. I've talked about the oxygen at birth, right, for resuscitation. 100%, 21%, 30%. See, finally it will find a good place. So you are absolutely right. The message is that one should not stop looking for it. One should start selecting babies more carefully to minimize the harm that could have been caused by an inadvertent selection of babies and address to treatment.
Thank you so much.
Thanks, Amir. Anne-Marie, do you want to chip in?
Yeah, I was going to come in a number of points. I think one of them is that you highlighted in your talk, which was a lovely talk, Samir, thank you very much, that there is actually quite a lot of emerging evidence from the post-hoc analysis of a number of trials, more than just PDA Tolerate and Trio-CAPI, but also from Dean Busman's work and from others, that prolonged exposure to a shunt is bad for you. We also see it from the lack of equipoise studies that we did in PDA Tolerate. The clinicians who felt the babies were particularly sick actually got ductal treatment, and their survivals were better than those babies entered into the trials. And trials become murky and difficult to interpret, but we mustn't actually lose sight of what Bikash has been suggesting, in which I'm sure you'd agree, is that sitting in cardiac failure long term and having multi-organ impairment for these small babies is not in their best interest. But the sort of noise that's come out from the very early trials in the first 72 hours does seem to be clouding people's judgment at the moment, and that's a big concern. And I just wanted to come back to sort of, the idea that we need to treat in the first 72 hours. I've always felt a bit uncomfortable about it, because that's a period of huge hemodynamic transition. You get changes in SVR and PVR. And even with the sort of screening criteria that you had in baby Oscar, I've seen babies with a duct of over 1.5 millimeters of continuous left to right shunt who I would have killed by giving Brufen, because they've got functional pulmonary atresia and the SPR is high and the shunt remains left to right, even though there's pulmonary hypertension. And I suspect that's actually maybe what's going on. I may be wrong, but I do wonder if Brufen, which has now been painted as a toxic bad drug, is actually not a bad drug. It's just been given perhaps at the wrong time. To a group of babies that might be very vulnerable to what happens to their duct, rather than vulnerable to the effects of Brufen on their wider development. Because it's very odd it's not come through elsewhere, but that noise did come through with the early Brufen prophylactic studies where babies died of acute pulmonary hypertension. So yeah, I just wanted your views, I suppose, first of all, is do you really believe that Brufen is a bad drug, or it's just something about when it was used and how it might have been used? And would you agree that we still need to be looking at phenotyping the early neonatal hemodynamic status, and be very, very wary of not paying attention to PDA.
I think very recently, Bill Bendis has very beautifully summarized, this particular point that what you have said, and I will, just share with you all. It is so. What it is? It is not that we don't know whether there is a benefit or not for the closure of the ductus arteriosus, but we know that there is no benefit in the population and for the indications that have been studied in these trials. So I think what we are saying is in the remits of the trial design for the gestation, for the intervention window and the drug, the answer we have is a foolproof answer. The question is, if you expand the selection criteria, you change the window of intervention, you change the intervention as well, will you get the same answers? We don't know. But the data which is showing from various studies that have been done so far, what it is disclosing is should we blame ibuprofen? Now the trials that have been done in the recent past, they all used ibuprofen, right? So clearly that is showing it. Now, what about paracetamol? The trio copper trial, prophylactic treatment, we need to see what the results in detail are, and then we can probably make judgments from there. But from the post-hoc analysis, what is coming in, I don't think we need to rush in unless the child is in failure or hypotension to go in and treat this baby, which is in fact a clinical reason to treat it. But otherwise, waiting for a week for a duct and not leaving it for weeks is probably the right way. That baby is still needing ventilation. Baby is still having a shunt which is of significance and is a week old. We need to start thinking, what do we need to do with this duct? Should we sit on it? Probably not, because some of these ducts will need treatment, and that is where the question is, how do we identify these babies? How long we should be leaving it? And as Vikas said, and you mentioned, is leaving them for times on, it will affect a long-term outcome on the cardiac health because the heart is in failure and it's just like cardiomyopathic heart, right? So it is and that could have the repercussions in the future, which we don't know yet. So I believe that yes, early treatment possibly does not have advantages because of the concerns, but leaving at least a week or 10 days, and if the duct is causing a trouble, I think it is a time to start thinking in these babies.
Thank you, Samir.
Thank you.
Marie, do you have any follow-up comments?
No, I think I agree that careful early analysis of the sort of hemodynamic status and supporting is required, and then consideration of treating persistently large ducts into the sort of 7 days of life and onwards, I think is supported by the current evidence.
Yeah, thank you. There is some questions here about which drug do you choose, ibuprofen or acetaminophen. I think we've answered that. I suppose ibuprofen would be your first choice unless you have contraindications like, kidney problems or platelets, etc. But in Iowa, the acetaminophen is their first approach, so it's probably center-based. There is also some comments about higher mortality with paracetamol. I think we haven't seen that one it's mentioned here in the question. It was in JENS but not yet published, so we'll just wait for more evidence. I would be cautious about that interpretation because we've been using paracetamol for a while now. I didn't see any indication of increased death, but we'll wait to see that. And I think, Samir, we probably, just to end our session, I think we would be really good to do more collaboration in the UK and more kind of studies among our teams, join forces and maybe come up with a research plan about PDA in the UK. That would be really good. So I will be open for conversation about that, and we'll appreciate collaborative efforts from the team as well.
Excellent. I think that's the answer. I see the questions which have evolved from the evidence so far, they needs to be addressed. And by any means, I can certainly say as a first-hand experience, the point you start thinking of the question and you get the answer is minimum 10 years, if not more. So can you wait for 10 years? No. So we need to find ways of assessing the situation and minimize the harm as well. So clearly, it is not as easy as we think that we'll have the answers. No, as I said at the start of the talk, that probably now we know what not to do rather than what to do. And the two questions that I mentioned in the start about the baby that was a hypothetical case, a baby that is in the first 24 hours, yes, that is a duct was left, right, and center treated. Now people are concerned about it. But the second option of 14 days old causing a trouble and a large duct, definitely I think that is a baby which we need to think carefully that yes, this baby must be treated.
No, beautifully said. And Mahmood, if I add one more thing just before your closing, is as Samir rightly mentioned about do not harm. One of the things which I increasingly see is, of course, we need to screen and look after these babies, but we need to be very cautious when we are screening them. Is to ensure we have a whole thermal care bundle. We don't spend too much of time. Normally, as we keep on saying, the image acquisition phase is 8 to 9 minutes, and you can acquire everything. And we need to ensure that babies have a good thermal and hemodynamic stability when we are scanning this baby. So, just have to be mindful about that. I don't know of any trial which has been done has ever looked into between a conservative approach and expected management to intervention approach, whether they have looked into those intervention impact of hemodynamic assessment on the baby too. So something that I think so it's important for me.
Absolutely, because
Can I just comment on that? It's a fabulous point which Vikas mentioned, and that has always crossed my mind because it's in any unit, it's a spectrum of people who do these scans, right?
Yes.
And particularly it's a training unit, you have the fellows who will be also doing it as part of the training. So at Sidra, what I have done is that in our registry that we maintain, apart from who is doing the scan, we have how many images taken and how much time from start to finish. That is recorded on the sheet, so that the data is there that who is taking how much time, so the feedback can be given and we minimize that time. So for the registries, if we start developing, I think this is very, very important about how we are managing the babies.
Thank you.
Absolutely. And you might be aware, Samir, we're currently doing our neonatal hemodynamic framework in the UK. So we're going to discuss all these details about, points how to perform the comprehensive assessment, but also things to be aware of. So hopefully that will come up soon for everyone. Thank you very much. Back to you, Liam.
Thanks very much. Once again, I want to extend my thanks to Prof. Samir Gupta, who's actually in India at the moment, so is presenting to us. It's about 7, probably 8 o'clock over there as well. So thanks again very much for your time there. That was a fantastic talk. We've got another session in 2 weeks' time again. I believe it's about congenital diaphragmatic hernia, but the links will go out on the WhatsApp group. Please feedback. Your feedback's really, really welcome and feeds into what we're doing as a group. And thanks very much again, Prof. Gupta, for such an excellent talk. And I look forward to seeing you all here again in the next couple of weeks.
Thank you again. Thank you, everyone.
Thank you.
Take care now.
Thank you. Cheers. Bye-bye.
Thank you for watching. If you enjoyed this, please check out the other webinars on our channel.